Good morning, good afternoon, good evening to all of you who are joining us. I'm really pleased to spend some time with our number 19 webinar for us here in Australia for the Australian UDI implementation. Today we're really fortunate to have a guest speaker join us from the US Learning UDI community and the AHRMM, so Mike Schiller, and I'll introduce Mike in a moment. So Mike has offered to talk to us about the benefits of UDI and the considerations for UDI within the healthcare sector. So Mike has an enormous amount of experience, and we would really appreciate and thank Mike for his time. In addition to sort of hearing from Mike, I know a number of you are interested in having an update on what we're doing with the implementation of UDI here in Australia. So I'll give you a little bit of an update as part of that sort of process and talk through that. And then we'll have a break and obviously, depending on where we land from a time perspective, get to as many questions as we can and answer a number of the questions that you either have in relation to any material presented today, or alternatively in relation to anything that that may come up through the conversation. So thank you again. And like I mentioned, the first speaker is Michael Schiller. So Mike is a Senior Director of the Supply Chain for the American Hospital Association and the Association of Healthcare Resource and Materials Management in the United States as well. Mike has 35 years of experience in the healthcare and supply chain, has an enormous and an immense understanding of both healthcare, supply chain, and also then how does all of that come together in terms of sort of a supply chain enabled point of care and be able to deliver points of care. Mike has an enormous amount of experience in relation to UDI and is an active member of the AHRMM's Learning UDI community as well. So if you haven't seen and seen the information or the content that's coming out of the Learning UDI community, I really strongly encourage you to have a look at that material. Brings a lot of great thought leadership in relation to the implementation of UDI, but also how does that work within the healthcare and the supply chain sector. And the work that Mike and the team has done has been exceptional and really valuable to us here in Australia in terms of the implementation of UDI, but also for for what we do in Australia, but also just understanding what's happening globally. Mike has kindly offered to, he'll probably regret putting his hand up, but kindly offered to me to do a presentation on what he's seeing and what's happening in the US around the implementation of UDI. For those of you who don't know, the UDI within the US is really 10 years old this year, and recently just I think celebrated its 10th birthday, and really has been moving into the process of having the unique devices on the labels, on the devices, and then looking at how it starts to weave its way into the healthcare sector. And the work that Mike and the AHRMM team is doing has really been helping to drive that, but also there's a lot of really great insights in terms of how that can benefit the healthcare sector. So Mike is kindly giving us time. So with no further ado, I'd love to hand over to Mike and pass the control to you, Mike.
So thank you again for that kind introduction, Gary. The pleasure's all mine. I'm honored to be asked to be a part of this presentation and to share some of our learnings. You're right. We just celebrated the 10-year anniversary. September 24th of this year was 10 years that the UDI rule went live here in the US. And I wish I can tell you that we've got everything solved and it's all systems go, but something as complex as this and as complicated as the supply chain is, we're still working through it. But to your point, the Learning UDI community has been a real asset to all of the stakeholders here in creating, number one, a community model, but more importantly, the opportunity to solve the challenges that come with a program like the UDI, but solve those with a collective mindset rather than organizations and stakeholder groups making up their own solutions, and you end up having a very fractured environment. So really pleased to be able to provide that resource. And we've been going at this now, I want to say 7 years with the LUC. So a lot of good resources out there. But let me jump into the presentation here. And what I want to start with is actually a slide from our group at the FDA, Indira Kanduri and her team. And what this really just highlights is the number of countries that either have current UDI regulations in place or that the regulations are under development. And this is impressive when you look at the areas that are covered by either current or developing UDI programs. And it really speaks to, I think, the need to harmonize a lot of the UDI. I think some of the challenges I'll get into here in just a moment or two are going to be associated with this number of UDI programs at a global level. But you can see, we've got U.S., European Union, TGA, where you guys are at in the development and launch of your program, South Korea, Turkey, Saudi Arabia. If you look at some of the major countries under development, India, Japan, again, Australia, Brazil, Singapore, Egypt. So a lot of activity in the UDI space, which is, I think at the end of the day, it's fabulous. I'm excited by this. You think of COVID here in the US, we had the FDA began to release what we call the emergency use authorizations. And that allowed non-FDA approved product into the US healthcare supply chain. Sure would have been great to have a global harmonized UDI database to begin to validate some of that product that was coming into the supply chain. So programs like this really excite me with the fact that we've got this many countries engaged in the development or live under the UDI programs. But again, I think it does speak to the need of harmonizing a lot of the requirements across these different UDI programs. So let's jump into some of the barriers for adoption. And I think one of the key barriers is lack of interoperability. When we begin to think of all of the technical systems, the ERPs here, enterprise resource planning systems, our material management or supply chain applications, when you think of electronic medical records and again, just the number of electronic medical record applications and the lack of a defined interface to share information. I know that I believe it's FIHR is the one of the standards that's coming out. But interoperability is definitely one of the technical barriers that we're seeing across the field and limiting just how rapidly we can share information across these different platforms. Along with those technical barriers are limited IT resources within the hospital setting. So when we begin to think of a program like the UDI and we want to implement this program, you're going to need to require your information technology professionals in the hospital setting. So we need to look at that. Lack of integration, lost inventory, manual data entry, missed opportunities in decision making. I think these are some of the barriers right now that we're being faced with. Multiple DIs. This is something that I had mentioned. Again, when you've got all of the countries that have either programs in place or are beginning to develop their programs, we're going to see more device identifiers coming into the marketplace. And to be perfectly honest, this is one of the struggles we had pre-UDI, where you had multiple catalog numbers. You could have the same item in your item master 6 times because you had a different catalog number. Maybe you purchased it from a different distributor or supplier at one point in time, or maybe the catalog number changed. So again, from a tech standpoint, how do we manage those multiple device identifiers when you begin to think that the UDI is at the packaging level? So we need to have the fields to be able to track all of those multiple device identifiers. Here in the US, we have what's called the Global UDI Database. And one of our work groups, I'm trying to think which work group it was, but the report that came out on a recommended practice is that the device identifiers, the multiple device identifiers, appear in the Global UDI database, but with a kind of a bi-directional view, if you will, right? So if I go into our Global UDI database and I select a device identifier and there's a more recent identifier, that I'm alerted to what that new device identifier was, or if I happen to click into the new device identifier to have that backwards compatibility or that backwards look to see what are the previous device identifiers. So again, just some of the technical challenges that we're facing around multiple DIs. And again, a lot of our ERP systems, a lot of hospitals may have older versions of these ERP systems and don't have the capabilities. And so what we're seeing is the management of multiple device identifiers being managed through a spreadsheet or some other mechanism that sits outside of the ERP. Again, not the ideal situation, but definitely it's a way to manage it, but it's not the ideal management where we do need to see those extra fields. Provider recommendations to minimize, again, UDI device triggers. What are the triggers that will cause the manufacturer to create a new device identifier for that product? A lot of these products look the same, but again, because of the differing requirements, manufacturers may have to create a new device identifier. So it's really one of our recommendations to governing bodies is, can you take a look at what those triggers are? Again, can we harmonize what those triggers are to avoid or at least minimize the number of device identifiers that are coming into the marketplace? And then having the required field in databases, as I just mentioned, where you can do a backwards look or a forward look to the device identifiers out there. When we begin to think of scanning in a clinical setting, one of the biggest points of frustration for the clinicians is to scan a product and not have that product information come up. And that could very well be because we've got an item with a one device identifier, but the device identifier that's in the operating room or the operating arena has a different device identifier. Maybe it's trunk stock or some product that a sales rep brought in. And so again, some of these inconsistencies and these challenges with multiple device identifiers can really disrupt some of the scanning programs. And really, if you think about it, when you're in that OR setting, there's a cadence, right? There's a rhythm that is taking place in that room, and you don't want to be throwing that off because now I can't scan and get that information into the item master. And the nurse, to be honest with you, isn't going to try 2 or 3 times. They'll try once, maybe twice. So how do we correct that again through multiple device identifiers? Some of the other challenges are scans. Some of the barcode labels, the UDI label is incorrect and it's not scanning properly. So one of the things that we're doing here is we have a program, a number of hospitals are starting this, where they're beginning to track the scan performance of the UDI label. So there's a number of reasons why a scan may not work. The barcode label could be damaged. You don't have the device identifier again in your item master, or there's something wrong. There's a character that should not be in that UDI string, and that's not allowing the barcode to be properly read by your scanning software. So those are the barcode labels that we want to begin to identify, and then work with those suppliers and say, hey, we've got a problem with this product, this barcode label. So again, it's a very iterative process, but these again are some of the challenges that we're seeing on the provider side. Additionally, financial barriers, right? Margin pressures in hospitals are it's significant. And I don't know that it's going to ease up anytime soon. So financial barriers, capital budgets, the money allocated to these programs may not be there. And it may not support the acquisition of scanning software. So this is one of the things that we did within the Learning UDI community, and we'll get to that in just a minute when we kind of turn the conversation to the positive side of the equation on the number of success stories out there. So this is why I put barriers to adoption first, right? I don't want to end with this, but we'll talk about how we're addressing this because of the realization that resources are going to be scarce, whether it's capital, whether it's human resources, training, etc., whatever those resources may be. Something that the FDA has just begun to do now is to monitor the data quality and they are beginning to issue warning letters to companies that weren't in compliance with regulations. So this is something new that we're starting to see, where there's a little bit more focus being placed on the quality of the data in the global UDI database is really critically important. And so we have those inconsistencies or incorrect data, in whether it's the global UDI database or just compliance with the regulation. Again, the FDA is beginning to start to focus on that and has sent out letters to these manufacturers. All right, let's talk about the success stories and some of the benefits that we're definitely seeing. Track and trace. This is a term I know that's been very, very widely used here in the US coming out of COVID. Track and trace from a Drug Supply Chain Security Act. Again, coming out of COVID with the emergency use authorizations, how can you track and trace the product? How can you ensure the integrity of the product, that you're not allowing counterfeit product to come into your supply chain? So because the UDI can be tracked through the entire supply chain, it really does counterfeit, or it really does counter or eliminate, reduce counterfeit products from coming into your supply chain. So this, again, is something that's incredibly important. We want to make sure that the products we're using in the care of our patients are in fact, the products that we should be using, and deliver the best outcomes that we intend them to produce. The FDA is also requesting that the UDI be used in recalls and in adverse event reporting. So this is something that we're seeing now. More and more recalls are beginning to contain the UDI-DI, the device identifier, and the UDI-PI, the production identifier information. That's critically important, because as hospitals begin to consume this data, whether they're consuming it on the supply chain side as their stocking product, or they're consuming the data and uploading it into the patient record during the course of a procedure, that those two identifiers, device identifier, production identifier, are going to be critical in identifying patients who could be impacted by the recall, and more importantly, or equally importantly, where that product is, so we can pull it off of the shelves and not use it during the course of a case. Hospitals are using the UDI and identifying these recalled and expired products prior to use in the surgical setting. So they could be scanning the products and identifying that this product is either recalled or the product is expired. The last thing you want to do is find out that you've used that after the case is wrapped up. So a lot of scanning, a lot of focus on identifying these expired products, or even a short expired product, right? Do you want to use that in the case? So a lot of this information on the front end is going to be very, very important. And that's why we're starting to see more hospitals begin to scan at least the implantables, right? What we call class 3, the high risk, the critical implant items. They're beginning to scan these items. Transparency. This is a probably an overused word now coming out of COVID. You hear about transparency all the time. You hear about visibility, but I'm going to tell you, it is so important to have these elements in your supply chain. So important to have them in the supply chain, the healthcare supply chain, not just the hospital, but across the entire healthcare field, so that we can understand what we have, where we have it, right? Those are so important. During COVID, the big terminology that was used was burn rate. What's your burn rate? What's your burn rate? And everybody had to report and understand what their burn rate is. Basically, the velocity. How fast are these items moving through my hospital? How fast am I using these? So transparency and visibility are critical into understanding what I have, where I have it. Will I run out of product? If there's a back order situation, understanding what some of the potential other products are that I can use. Again, going back to track and trace, lot and serial number traceability. Utilization and standardization. This is an area where we're really beginning to see a lot of traction around the UDI. When you begin to think of the real-time product tracking, again, getting back to that velocity, how quickly products are moving through my health system, how quickly I'm using these on patients, and who's using what. If I've got 5 surgeons that all perform hip surgery, who's using what? So if I can understand my utilization and then look at those opportunities to standardize, because variation is the enemy of efficiency, right? If we can standardize, we can ensure that we've got similar outcomes across our patient population. So again, this is an area where we're really beginning to see a lot of uptake and a lot of traction when it comes to UDI adoption. So some of the success stories that we're seeing here, there's a hospital in their cath lab that they're using what we call a PIM, a product item master. A lot of third-party organizations will host these product item masters that have a lot of standardized and normalized data, and they'll keep and track the UDI information in those in their item masters as well. Hospitals will scan those, and they'll capture the information. Some will even go out to the Good ID and bring information in. But we're seeing scanning in this hospital, St. Luke's, is scanning products in their cath lab and then uploading those products into their EMR. As I mentioned earlier, part of that scan process is to identify short, dated, expired, or recalled product prior to using it on the patient. Another example is UT Southwestern is managing their crash carts utilizing the UDI. So they'll have packs, custom packs. These are packs where you've got a number of different products that you'll use, but instead of the individual products, they're all already custom packed. So they will put the shortest expiration dated product that's in that pack. Let's say there's 25 products in that pack. Whichever product has the shortest expiration date, that will go on the outside of the pack. They can then scan that barcode and understand which pack has that product in it. They can then take the pack, open it up, or if the product is expired, they can take the pack, open it up, pull the expired product out, reuse the rest of the individual products, but more effectively managing their short expiration date or expired products in their crash carts. So just this process alone, just crash carts in this hospital resulted in an $8,000 reduction in expired products, because if they could identify short dated products, they could use those before they expired. More importantly, they experienced a $30,000 reduction in labor costs. They had multiple people going around and tracking these crash carts and the expiration date of products. They now have one person that does that. So they've been able to reallocate these resources to other operations within the hospital. Another example, and this is something that I mentioned earlier, this is due to some of these financial pressures. We began at the Learning UDI community to look at what is everybody doing? And everybody is EDIing their products. Well, not everybody, but most every organization is utilizing EDI to transmit their orders to their distributors or to their suppliers. Our thinking was, rather than looking at a net new program where you'd have to go and get some scanners, you'd have to have IT resources to implement those scanners, you have to go through training with the clinicians, there's costs and resources there. Let's focus on something that everybody is doing. And so what we've been promoting is start with one supplier. Find that supplier that you do business with that is utilizing the UDI in their programs, and take those items in your item master, update them with that device identifier information from that manufacturer, and then begin to EDI transact with that manufacturer. Start with one, work out the kinks, get those EDI transactions flowing, your 810s, your invoices, your 850s, your 855s, your 856. These are your POs, your PO acknowledgments, your shipping acknowledgments. Get all of this information electronically going back and forth between the organizations and eliminate a lot of the inefficiencies that you have and errors in these transmissions because you're utilizing the UDI. So a couple of great case examples or success stories here. Cook, a medical manufacturer here in the US, found that when they transact with a hospital that is using the UDI, their PO costs are $60. It's $120 when they're transacting with a healthcare organization that is not utilizing the UDI. And what Cook did was they took a look at 3 years of contract savings, and they found that they were saving $1.2 million in savings by transacting with some of their hospitals utilizing the UDI. Frederick is another hospital up in the Wisconsin area, and they began to do this. They selected and partnered with Gore, cleaned their itemmaster, and began to transact with Gore. The efficiencies from an operation standpoint were significant, and they have since expanded that program now, and they're working with Cook and using the UDI in their transactions with Cook. Intermountain, a very large health system out in the mountain states out in the western US, they're doing the same thing, and they're doing it with any and every supplier that is able to transact with the UDI. So again, a great way to really promote adoption of the UDI in a way that doesn't cost you anything other than just a little bit of resource time, and you're not doing the big bang, clean my entire item master. You're just doing it one supplier at a time. Another real world example of the UDI is Kaiser. Kaiser uses the UDI in their case build process. So basically, they're scanning the products that they're putting on their case carts. They're scanning products that are unused during the course of that surgical case, and they're putting those products back on their shelves. And with that information, they're fine tuning their preference lists so that their preference lists are an accurate representation of what is used during the course of that procedure. There's a tremendous amount of efficiency on the workforce side because now I'm picking just the products that I need to pick, and I'm not going back and forth for either products I don't have or putting products away that I'm not using that I've already picked and I really don't need to pick because I don't use those products. So they're beginning to see a lot of operational efficiencies there within their procedural setting. A couple of examples of point of care or point of use scanning. Again, Geisinger is doing this in their cath lab. I mentioned St. Luke's, which is doing it in their cath lab. And we had a small hospital up in New Hampshire, North Country Healthcare, that was populating their itemmaster, the implants in their itemmaster with the UDI device identifier information and scanning those implants into their electronic medical record. And they were seeing, efficiency there because they could capture utilization so they could begin to understand which implants are being used across a specific surgical procedure. More importantly, they're populating the patient's record with that information as opposed to manually entering the UDI device information into the patient record. So a lot of success stories there. Let me go ahead and let's just jump in quickly here for the sake of time. We're going to talk about the road ahead, right? So what are some of the areas that we've got our sights set on, some of the benefits that we have yet to really begin to uncover? There's a couple of one very, very large system here in the US that is beginning to look at demand forecasting, right? That's the holy grail here on the healthcare side. Retail's been doing it for 40 years, so don't tell us that, we think it's pretty exciting that we're coming up with demand forecasting, but it really optimizes your replenishment practices. You're able to begin to share this information with your distributor, and you can imagine the upstream benefits, right? If we're all capturing the data that we use and sending that to our distributors, much like you see on the retail side, they can more effectively manage their supply chain and upstream from them their raw materials and other manufacturers that they're getting supplies from. So it has ramifications up and down the entire supply chain. Case studies, some of the things we're going to do here from the Learning UDI community perspective is we started out, actually, our very first work group was around identifying case studies. Who's using the UDI? What are the benefits? What are the next steps? Well, the whole field has shifted. Podcasts are very, very popular here. So we're looking at identifying case studies or these success stories. And let's just get a 12-minute podcast together. Let's just begin to seed the field with ideas around how organizations are utilizing the UDI. I gave you a smattering of examples here that show some of the breadth of these success stories. So let's just get that out in a 12-minute podcast. So that's something that we're looking at. 2017, we had a very, very comprehensive work group that built the business case for the UDI. This was meant to show pre-UDI and post-UDI business workflows and the efficiencies that UDI in those supply chain workflows and clinical workflows would bring about. We're looking to expand on that and come up with the 5-minute elevator speech for supply chain professionals to go to their senior leaders and say, here's why we need to implement the UDI. Here's the bottom line savings that we're going to see right out of the gate. You need to lead with the financial savings. And so we want to create just that template that shows some of those benefits right out of the gate. The development of a maturity model. This came actually out of a conversation with Gary and the idea of developing a maturity model. And that can be an outgrowth of our focus on the business case for the UDI, but really begin to show a roadmap on where you might be as a healthcare organization and what steps you need to take to move to become fully adopted and utilizing the UDI across your clinical and supply chain workflows. There's a large group, it's called the Healthcare Transformation Group, which is made up of 5 healthcare systems here in the US. The health systems are Geisinger, Intermountain, Kaiser, Mercy, and the Mayo Clinic. The AHRMM works very, very closely with HTG. And we do a lot of work sharing around UDI and UDI adoption. So some of the areas that we're looking at are metrics, right? What metrics can we begin to put out there that people can begin to track their progress? So at AHRMM, we have our KPI keys, which is a platform that has a number of different metrics, operational and aspirational. And one of the areas is around resiliency and data standards. And so we already have some metrics developed. So with HTG, we want to work and define, are these the right metrics? Are there additional metrics that we should begin to track? This feeds into the maturity model at the end of the day so that you can track your progress. We want to develop a feedback loop to correct data in the good idea. I started out our conversation with quality and the focus on quality and the information that's in the global UDI database. And it's a continual cleanse. And so we want to create some type of feedback loop between the hospitals and the providers and the suppliers, and identifying where those data inconsistencies exist and how to clean those up. And then to close out our conversation here, it comes down, there's a call to action, right? The manufacturers have invested millions, in some cases tens of millions of dollars in compliance with the UDI. Hospitals, it's voluntary right now. So the call to action really is to continue to just move towards full provider and full stakeholder engagement across that provider community. Because it's voluntary, that's really the reason that LUC came about, was just to highlight these many examples and come out with the recommended practices. So really, how do we continue to move the needle forward in provider engagement? We're looking at UDI and claims. That's an area that we were hopeful was going to pass. It didn't. And we're going to continue our focus and our efforts on capturing the UDI in claims forms. And a simpler objective or call to action really is to begin to work with our GPOs and our suppliers and really require all contracts and price files to contain the UDI information. So we need to begin to put the UDI out there in all of these different segments that we work and operate within as supply chain professionals. So it's easier to consume, it's easier to bring into our item master, it's easier to transact with. The tremendous efficiencies, you saw $1.2 million for Cook. That's some significant savings there that if we can all operate within a collective supply chain much more efficiently and effectively, the savings, workforce, financial savings is a benefit to all of us. So with that, Gary, let me turn it over to you. I think I talked far longer than I was supposed to, so my apologies.
So thank you, Mike. And I just sort of really wanted to say thank you for your sort of insights. And as you mentioned, and as we both mentioned, UDI is 10 years old in the US. Certainly the learnings that we have from the US FDA, but also all the experiences and information you've supplied. We don't want to wait 10 years to have this same sort of conversation here in Australia. So, the TGA is very keen and really appreciative of, the anecdotes, the stories, the case studies and examples you supply. And we're very interested in, having more of these sort of conversations with the community within the healthcare sector to help understand that. And as you've touched on, the benefits can be quite large. They also can be quite diverse, and to working out how we go forward is really our challenge. And certainly the TGA, the conversations the UDI team has been having within the healthcare sector is really about, well, a lot of people sort of starting to say, well, but this requires me to invest substantially in scanning, invest substantially in upgrading my, IT systems, the impact on our point of care staff, et cetera, et cetera. So, obviously there's a lot of concern, a lot of questions, as you touched on with the barriers, but your advice around, start small, start with something that allows us to, just identify the benefit and then grow up from that has been fantastic. And I think our opportunity to continue to work with you and sort of bring this to life here in Australia will be fantastic, and I really appreciate your time and attention. I do, for those who are attending and listening, I sort of do strongly encourage sort of looking at the AHRMM, the Learning UDI Community sort of website. There's some great and rich information there, and those sort of case studies will really may help resonate. And if there's any specific questions you'd like to ask the TGA around the implementation or the benefits, there's certainly work we're doing with a number of hospital systems, a small number of hospital systems now, to sort of bring this to life. We're very happy and very eager to work with you, because certainly we're very eager to make this happen as soon as possible. So thank you again, Mike, and I really appreciate the time. Just as a short moment, and I will sort of give you a bit of an update on the Australian UDI scenario and where we're at. So this is a build on the information that we provided within the last webinar, and essentially things are progressing really well in relation to us finalising the key components for us for the Australian UDI implementation. Most of it's working well, and there have been a couple of challenges we faced, but certainly for those who are within the medical device sponsor or manufacturing field, then we have opened up the Australian UDI database, and using that to test and trial this provision of data, and for the creation of the data for the first step in that sort of chain that Mike talked about, which is getting the data and the labels, etc., and all the information into a UDI database that then can be used by hospitals, healthcare providers to do some of the intelligence and interrogation that Mike mentioned. We currently have 1,338 records, and we have 81 sponsor organisations participating, and so we have a range of different information, different device types, and that's going really well. And I'd like to thank those sponsors who have been working with us closely and getting that together and putting that data in there. And it's great to see the cross section and the types of devices you're now starting to bring in. And really thank you for your feedback. So that testing environment also then allows sponsors to give us some feedback. We can look at the real life data and work out how we fine tune that, so make sure that we're ready to go when we need to. In addition to the sort of the standard UDI capabilities, you may recall that we have also added some additional capabilities into the Australian UDI database, which is to allow the storage and the capture of patient information leaflets, either as a document or as an electronic link to a URL to the manufacturer's or the sponsor's website. The reason for that was really as part of that, making it optional. If an organisation sponsor wishes to link their patient information leaflets with the UDI, it will give almost a one-stop shop, a single point for sponsors, hospitals, consumers, patients to start to come and have a look at. If I've got a device, I've got the information on the packaging around the device I have implanted, I can go to the Australian UDI database and start to capture information, or find out information about the product itself or its instructions for use. So that's progressed really well. We've had some good testing and feedback from sponsors, and that's looking like it's sort of starting to bed down now. We've also introduced the machine-to-machine method for those who are technically oriented. So we now have a machine-to-machine data submission using two methods, one which is using GS1's national product catalogue. So that's now able to send us data directly from the sponsor's IT systems into the TGA, as well as then finalising another method using the HL7 SPL standard that's used within the US FDA. So really the aim there is to make the path for transition for those organisations who are sending data to the US FDA, to make it as a simple step for them to be able to provide that information to Australia as well. Really then the opportunity opens up for us to sort short circuit or shorten up some of that 10-year period that we were talking about before. We have the ability, and we're sort of finalising capabilities around the corrections features, so allow sponsors to correct and maintain their data. So we recognise that there are genuine mistakes that get made in the data. So rather than forcing situations that create more and more of those unique device identifiers, UDI DIs that Mike talked about, give the ability for sponsors to correct, or manufacturers to correct that data to shorten up and reduce the proliferation of different identifiers, really just it's starting to happen. So, and the downstream effect is that means in a hospital or in a point of care, you're getting a smaller number of identifiers for the same device, and rather than leading to confusion about why are these things different, we start to simplify that. And then finally, we are really sort of our biggest hurdle at the moment is sort of for finalising our implementation schedule. And that is in the process of actually working through and consulting with sponsors. A key factor in relation to finalising that timetable, well, there are two key factors in finalising that timetable, which is sort of showing you on the slide here. The first factor is in the bottom left-hand corner, you see a little black dot, is we're essentially working with the regulatory drafters here in Australia with the aim of having our UDI regulations take effect from the Q2 2024. So those of you who participated in the last webinar, that you'll recognise that date as the date we're still working to. Our biggest challenge, or sort of the biggest activity we need to finalise in terms of firming up that date, is being sure that we get into the regulatory drafting schedule, or the program that the Office of Parliamentary Counsel is working through, to ensure that they complete our regulations in the time frame to hit that. So we're working with them at the moment to finalise what those drafting instructions are and how they draft that material. But a key factor to that has been also then our timetable. Those of you who are in the medical device manufacturing and have familiarity with what's happening in Europe, it does have a big bearing on what we're doing in Australia around our harmonisation with the European medical device regulations and reforms that they're doing in MDR. And one of the key considerations that it is something that we're working through and consulting with sponsors at the moment, is that the Europeans have recently moved the dates for when their UDIMED, which is essentially their European equivalent of the Australian UDI database, have moved it out 3 years to now commence in Q2 2027. So in doing that, we're now working with sponsors to understand, their readiness and their ability to supply us with data and what that would mean for our timetable. So over the coming weeks, we will finalise that consultation, which then allow us to sort of communicate out when our sort of more definitive dates and when we're looking for regulations to take effect. But certainly, it's an active process, and and there's been ongoing engagement and consultation with sponsors around that date. So working pretty hard to make sure those that information is sort of finalised by the end of Christmas, by Christmas, sorry, and sort of looking to have give some certainty to the industry around our implementation going forward. So again, just to wrap up, I'd just like to say thank you to Mike. We will take a slight break now, just for a minute, just to sort of regroup and allow you to do two things. One is to sort of raise any questions or look at the questions that have been raised through Slido. And if you see anything of interest, please feel free to use the upvote, the thumbs up for those questions. We will then come back and provide the next sort of 10 minutes or so with responses to those questions.
Okay, so we've got some questions that we had previously. In the essence of time, I think we've answered a few of these, Gary, already, but I'll just go through and you can let me know if you want to elaborate on anything. Can you show how real examples of when UDI has been used by the medical hospital institutions? So this might actually be, I know Mike's touched upon this quite a bit in his presentation today.
Yeah, I agree, Jasmine. And unless we'll see, feel free to sort of raise more questions. Mike's sort of giving us a good breadth of UDI benefits from both within the sort of the inventory, warehouse management, management of the inventory within the hospitals, but also some examples of point of care. If you do have any other questions or any specifics that you're looking for either, feel free to write to us at the UDI team, or again, there is some really good information on the Learner UDI community, which we will post as part of the sort of the information that we publish out for this webinar. So we will, if you're happy, we can move on to the next question.
Yeah, absolutely. And I think this one's been touched upon as well, Gary, but you might want to elaborate a little bit. What is being done to improve the traceability capability for hospitals, clinics, and GPs so that the full benefits can be seen?
Yeah, so it's a really good question. And so again, we touched on it. So there's a range of elements that need to be in place to sort of give us that full traceability. And certainly there's conversations that the TGA has been having with a number of state hospitals, some private hospitals as well. This is early stages in their sort of conversation around what they do to be able to sort of capture the UDI information into their sort of internal systems, but also then to ensure that it passes through the various the UDI then goes through all the various stages and points of interaction within the hospital or then through to the patient record. So we have mapped that out with some hospitals. We're sort of working through that, and then in the process of actually working out what they need to do to be able to put in place some of those mechanisms. I'll definitely be taking away from this conversation, Mike, to be able to say, let's just start simple and keep it 1 or 2 items and sort of work through that in terms of, you can identify the benefit. You can really see a tangible benefit without a major investment that it may be seen to be required. So we'll also be taking that through to that conversation. So there's still a bit of work that's yet to be done, and hospitals in particular need to factor that into their sort of programs of work.
Thanks, Gary. We've already touched upon this quite a bit, thanks to Mike, but we've got a question about the differences between what the US is doing and what is being done in other countries to enter and provide UDI data for medical devices.
Yeah. I don't know if, Mike, if there's anything specific that you'd like to cover. I think you're sort of looking at, I can talk a little bit about sort of other countries and certainly the provision of UDI data. And one of the things that we in Australia have done or looking to sort of finalise as part of our regulation and had policy direction on is ensure that we have a consistency of labelling. So a US compliant UDI label or a European compliant UDI label, as long as it meets the Australian sort of labelling requirements that exist today, then we will accept those from a UDI perspective. So there's 2 parts to that, which is obviously that will allow the introduction of products and devices that already fit within the US or the European medical device regulatory framework to sort of come in. And then we're working really closely with sponsors and international manufacturers to ensure that the data they supply us is as close to the European or the US data set as possible. There are some Australian unique requirements and some Australian specific requirements around how we regulate devices, and a really simple one is the inclusion of the Australian Register of Therapeutic Goods ID, so the ARTG identifier, and we look them to supply some additional information. But certainly working really closely to ensure that those devices can be brought into Australia easily, and then how do we ensure that we have those sort of technical methods to get the data into the Australian database. I hope that answers the question.
Gary, if I could add, as we embark on identifying the suppliers that we're bringing in and populating our item masters so that we can transact with those, part of our efforts with HTG is really to begin to develop a repository of those suppliers that are actively working in that UDI space from a transactional efficiency standpoint. And happy to share that information with you and the rest of the TGA to go ahead and use as see fit, because let's face it, we use a large subset of the same manufacturers and the same supplies, right? These are global manufacturers. So if we can identify some that, again, have robust capabilities, have already engaged with hospitals in the US on transactional data with the UDI, maybe that's a good place for you and your systems to start.
Yeah, thanks. That's great, Mike. And just a bit of a corollary to that is we also talking to some of the manufacturers of the electronic medical record systems as well, because if they're doing that in the US, then what do they need to do? So things like Epic, Cerner, etc. So they're the sort of start to bring those things in. So bring that into the mix and make that sort of take up in the hospitals simpler, we hope.
Great. And then the last question for this one, and I think we've already touched upon it, the vision of the government around next steps for implementation regarding regulation of healthcare facilities and costs.
Yeah, I'll short answer that one, Jasmine. I actually couldn't talk on behalf of the government and what their vision is in relation to that. So the TGA's responsibility obviously is that the regulation of the supply of the device into Australia. So we make that as a UDI will then make it mandatory for devices that fall into the UDI specifications. There's definitely work we're talking to, but there's a whole range of other stakeholders then around how we get that rolling through the various parts of the healthcare system. And certainly at the moment, I couldn't talk because around what the government's vision on that in relation to how making that happen.
So first question today, this is maybe one for you, Mike. How do US healthcare providers manage UDI DI triggers?
Sure. There's a couple of different ways that they're managing it. A number of organizations are beginning to work with third-party companies. Again, they've got PIMs, product item masters. It's an extension of your item master, and the third-party company is responsible for keeping that up to date. They keep all of the information normalized, right? The description, the UDI number. So they'll work with these third-party solutions companies around the management of that. Some will just create a spreadsheet and manage it outside of their ERPs. Those that we're seeing a lot of new investment in ERP systems and a lot of conversions. This is one of those areas where it seems it's every 10 years or so, right? You go and put the RFP out for a new enterprise resource planning system, and we seem to be hitting that cycle, and it's actually a very good time because the solutions out there now, the new versions, have those fields to capture multiple device identifiers at the product packaging level. So for those hospitals that are converting to the latest and greatest version or a brand new software solution, they'll have those capabilities within their enterprise resource planning system. But again, those who are operating on older versions that they do not have those fields, those are some of the other areas. Again, that third party or just some external management of the multiple device identifiers.
Great, wonderful. Thanks, Mike. Unfortunately, we've got to time. So I don't know, Gary, if you just want to sneak in one last question very quickly.
I might sneak in two, if that's all right, Jasmine. So the first one is there's a question about has there been any development of devices at multiple sponsors? So there has been, and as part of that consultation paper around the implementation dates, there's a proposed approach for that. So you will see that sort of paper in the coming weeks around how the TGA is proposing to address that. There was one question about how to register for the AusUDI, an Australian UDI database. On your screen, you'll see that email address, udi@health.gov.au. Please send an email to the team, that's Jasmine and her team, and they would gladly work with you to sort of get access to the database. And then one final one, if I may, Jasmine, will it be mandatory to upload electronic patient information leaflets to the UDI database? No, it won't. So as part of the requirement, it'll be essentially the patient information management material, that the TGA is looking, so the sponsors will need to maintain that, but it'll be optional for you to supply or sponsors to upload that information into the UDI database. It's another channel or another means you may be able to use to have that accessible, so it won't be mandatory. Apologies for those questions that we haven't had a chance to answer, and like Jasmine mentioned, we'll cover those as part of a response. So in closing, I'd again like to thank you all for all your time. Really appreciate the contribution and the questions that keep coming. Helps us sort of fine tune our message. But certainly the considerations now, as we're getting closer and closer to this finalisation of the UDI implementation, is adoption in healthcare. And the stories and the case studies you provided, Mike, really add a lot of colour and a lot of benefit to helping people understand what this means. And again, I'd like to thank you for your time and really welcome, continue to work with you as part of this sort of process. So really appreciate it, and thank you everybody for your time today.